I have the pleasure of serving as your moderator for today's seminar, which is the second event in a three-part series. Today's seminar, Implementing Best Practices to Improve HPV Vaccination Coverage, is organized by the American Cancer Society, the National HPV Vaccination Roundtable, Indiana's Immunization Coalition, and of course, our host, St. Jude Children's Research Hospital. Before we begin, a few housekeeping items. The recording, yes, today's event will be recorded. A link and a PDF of the slides will be shared with all of those who pre-registered. In addition, the recording link will be posted publicly after the event. Technical issues, please communicate with us in chat. By default, all participants are muted. Questions, we will be using the Q&A feature to take all of your audience questions. Please post questions throughout today's seminar. The speakers will join a panel at the end of the conversation today, and we'll address those questions either in the panel or in real time after they present. Polling, we love to know what you're thinking, so we'll be using an interactive polling program called Mentimeter for you to join the conversation. We'll explain how that works soon. And lastly, CEUs. We know many of you love to get credit for these conversations, and we want to thank our friends in Indiana for helping us do so. You must attend the entire webinar and complete the evaluation link via SurveyMonkey at the end, and we'll share that link in the chat box later. So let's talk about the context and the purpose of today's discussion. As professionals interested in vaccination, you are well aware the COVID-19 pandemic has negatively impacted routine vaccination delivery. In fact, the impact on HPV vaccination orders provided through the Vaccine for Children's or VFC program is notable. CDC's Immunization Services Division data shared with us shows that public sector HPV vaccine orders have not yet rebounded to levels from before the pandemic. The graph you see here shows data trends for HPV-only VFC orders over the past 4 CDC fiscal years. The dark purple line I'll call your attention to is 2022, and it represents the most current data from last October to August of 2022. Now look at those summer months, the season when we typically see higher rates for back-to-school vaccination. Over the past 3 years, HPV ordering rates for VFC have been lower than 2019 orders between May to August. This is very worrisome news for cancer prevention. It will take all of us working as champions from wherever we sit to pave a road to recovery in 2023. Today's speakers will outline actions which have proven impactful at several levels. You'll hear about provider and system changes in Washington from Dr. Sherri Zorn, state and organizational policy changes in Illinois from Ms. Samantha Olds, and coalition initiatives and peer-to-peer learning from my ACS colleague, Katie Crawford. You are guaranteed to leave here today with valuable learning actions to take and apply directly from each presentation. So our learning objectives, they essentially boil down to 3 essentials. We want you to learn effective strategies around age 9 initiation, identify key steps for building statewide partnerships with Medicaid, and third, explore and explain why learning collaborative models hold promise for quality improvement between organizations. So we're going to start with our first audience participation. So grab your cell phone and we're going to try a Mentimeter question. So on this slide, you see a QR code. So you can either use your phone and grab your camera setting and scan that QR code, or you can go to menti.com and enter the code 6205-2019. So our first question, which state are you joining us from today? Let's find out where people are. Nebraska's representing. Indiana, a strong Midwest. Oh, here comes some Southern. Kentucky, I see you. Illinois, starting Texas. Don't mess with Texas. They're here. Glad to see you. Glad to have you. Virginia, all right. Okay, so strong showing. Great. Thank you for doing that. You got your practice. So now we'll do a second question. Help us better understand what does it look that you're looking to learn from today's webinar. So again, QR code, it should automatically pull up for you the next question on your cell phone if you have it, or on your computer browser. What are you hoping to learn from today's seminar? And I think we might, there you go. Next slide, that's right. Ways to improve vaccination rates. We're definitely going to give you ideas. Getting families back in, best practices. We have a lot of those coming. Back on track after COVID. You're going to get excellent examples from Washington. How can I incorporate vaccine in my COVID-19 work? Excellent. Panelists, calling your attention to that to pull forward in your remarks. Rural EBIs, strong recommendations. Great. This is very helpful for our speakers to think about. So I'd like us now to go to introductions of our first speaker. She is a one-woman force of nature for HPV cancer prevention in my book. Dr. Sherri Zorn is a general pediatrician in Seattle, Washington. She completed medical school at UCLA and pediatric and chief residencies at the University of Utah, so West Coast represented. After more than 25 years in private practice, she now spends most of her time as a quality improvement coach with a focus on vaccinations. She collaborates very importantly with Washington State's HPV Free Taskforce, the American Cancer Society, the Washington chapter of the American Academy of Pediatrics, and the Washington CHIP Child Health Improvement Partnership. She also serves on the National HPV Roundtable's Best Practices Task Group. You're going to hear a lot of great information in the next 15 minutes from Dr. Zorn. And again, please use the Q&A box to add questions during each panelist presentation. Dr. Zorn?
Thank you so much, Jennifer, for the kind introduction. And I have to say, I'm really excited and a little bit nervous to be here. This is one of my favorite topics, HPV vaccine and starting at age 9. I'll be talking from a provider lens and quality improvement lens, but I think if you're here from a state team or a systems or organization, you will find things in messages in my talk that will kind of teach you what to do next to improve HPV vaccination and really support starting at age 9. Next. So what we know is, HPV vaccine is powerful cancer prevention. It can prevent 90% of the 6 HPV-related cancers. So that's amazing. And we also know that the age of vaccination really does matter. It's best to finish the 2-dose series before age 13. And the 2 doses are separated usually by 6 to 12 months. And there's a couple of reasons why it's really important to get the vaccine finished by age 13. First of all, we know that the 9 to 12-year-olds, they develop the highest antibody titers compared to any other age, and that the immunity doesn't wear off. So they have the best immune response. We also know that once kids get to age 13 and above, their risk for exposure to HPV infection starts increasing. And in order for the vaccine to really work to prevent cancer, we need to get kids vaccinated before they're exposed. And finally, some great data has just come out of England. And what they found was that when kids were vaccinated at age 12 to 13, it provides superior protection, 87% against cervical cancer incidence. And as the rate of vaccination increased, that protection really went down. So it's really important to get done by 12 to 13. Now, we also know that the routine strategy in the United States has really been to bundle the HPV vaccine along with Tdap and meningococcal vaccine at age 11 to 12. And this is really a sensible approach. There's nothing wrong with the bundle, except the bundle doesn't catch everybody. And what we find is that when you start the vaccination, you start recommending at age 11, if a patient is excited to get all 3 shots at once and they have no questions, then great, the bundle works fine. But if a parent says, gosh, we only want 2 vaccines, or I have questions, and or I only want what's required by this, by the school mandate, then what they usually do is they push off the HPV and you've missed the bundle. And once you've missed the bundle, you might have missed your opportunity to get that patient vaccinated because they may not be coming back for a couple of years. So bundle works when the patient's willing to get it, but really as a strategy, it hasn't been working great. And we know that because that's not working great, because when we look at the NIS teen surveys year after year, the rates for HPV initiation and completion They lag really far behind Tdap and meningococcal vaccine. And we still are far below the goal of 80% vaccination. Next. So it's time for a new strategy. And that new strategy is to start HPV vaccine at age 9. Now, we've been able to do this. That starting at 9 is not really a new thing. It's becoming more popular now, and people are realizing that it's okay to do. And it's really important for you to realize, everyone here, and I'm going to say this twice, starting HPV vaccine at age 9 fits completely within the CDC ACIP guidelines. It is not going against them. And that's really important to understand because there's a lot of confusion. A lot of people think that you can't start it until age 11 to 12. And the fact is you can start at age 9 and you're still in compliance with CDC ACIP guidelines. And this starting at age 9 is fully endorsed by the American Cancer Society, the National HPV Vaccination Roundtable, and the American Academy of Pediatrics. And the goal is to start at age 9 and get both doses completed between the ages of 9 to 12. Next. So you might wonder, okay, why at 9? Is it about the sex? Like, are 9-year-olds sexually active? No, that's not it. You start at 9 because it's just easier and it works better. You can get more kids vaccinated with less effort. So starting at 9 gives you a lot more time, in fact, 4 years to get 2 doses completed before age 13. And we found that this is really helpful, especially if you have, let's say, a pandemic and there's disruptions in care. If you start at age 9, and even if the patient misses a visit or 2, you can still get them completed on time before age 13. We also find that when parents are hesitant, they may need a year or 2 to learn about the vaccine and decide to get the vaccine. So if you start at age 9 with your first recommendation and the parent declines, it's okay. You can bring it up again at age 10, 11, and 12. And studies show that when parents initially say no, 70% of them eventually say yes. So you need time to be able to make multiple recommendations. We also have found that starting at age 9 just results in an easier conversation with parents. You can focus entirely on cancer prevention, and you really avoid that awkward discussion about sex that occurs when you start the recommendation at 11 to 12. And I'm not saying that pediatricians shouldn't talk about sex and puberty. We should. It just should not be in the same sentence as our vaccine recommendation. So they need to be separated. We also find that, and I alluded to this before, that many parents and kids like having fewer shots at each visit. So a lot of them bulk at the bundle, the 3 shots, and you want me to do the flu shot, and you want me to do the COVID shots, that's too many. So they like the chance to space it out. And when you start the HPV at 9 to 10, they can get that one vaccine or get that plus their COVID or that plus their flu. And parents and kids actually kind of like that. We also know that you compare the HPV vaccine with the 9 and 10-year-old well child visit, and that can really streamline workflow for clinics that actually provides excellent immunity and possibly even better immunity than making them come back in at the 6-month mark. And it's important because it avoids this extra shot-only visit. This saves time for the staff and for parents, so it's a win-win for everybody. And still, you're getting the kids vaccinated on time. Next. So those are the reasons kind of why you might want to do HPV at 9. But then you might say, well, is anyone actually doing it? And the answer is absolutely yes. So I'm going to share the story of 2 clinics in Washington State and Western Washington that adopted HPV vaccine at age 9. Clinic A was sort of the pilot clinic. They started in 2018. So they've been doing this work for 4 years. And Clinic B took this on during the pandemic in 2021. Both of them were urban or urban suburban, and almost all of their patients had private commercial insurance. Now, Clinic A was a pretty decent sized clinic, 10 pediatricians. Clinic B is huge, 85 pediatric providers, and a huge patient population. And then remember, since they were starting during the pandemic, they had to make sure that the interventions were easy to implement, sort of streamlined, and just implementing the most effective interventions, because there's just not enough time to do everything, and providers are burnt out. So they had to make sure that this was going to work and be simple. Next. So this was really a multi-level intervention for this quality improvement project. And these are the four kind of key pillars of the intervention. First was policy change. And that was to make a standard workflow that HPV vaccine was going to be recommended at the 9 and 10-year-old well child visits. This was standard. Every provider was expected to do this. And of course, if a patient was older, age 11, 12, even up to 17 to 20, they would recommend HPV vaccine and use a bundled recommendation as needed. So they continued bundling for the patients who needed it, but everyone else started at 9 to 10. The other thing was that they used their electronic medical record they harnessed the power of this to make an age 9 recommendation. Clinic B they had an HPV health maintenance prompt, and Clinic A had to do a workaround. They had to make an order set. But basically, reminders and orders make it easy for the providers to do the right thing. And right now, providers have so much on their plate that they're trying to remember to do. So you need to have these prompts for them to just remind them to do the right thing. A novel addition to this quality improvement project was developing this standard immunization schedule poster. It's big, it's 18 by 24 inches, and it's posted in every exam room. And you can pretty much see it from anywhere you sit in the exam room. This served as a low-tech visual cue to start the conversation, and I'll show you in a minute what the poster looked like. And then finally, what would a QI project be without provider and staff education? We wanted to make sure that the providers and staff were confident in how to talk about the HPV vaccine, and they knew how to give a strong recommendation, because we know that a strong recommendation from providers with that presumptive announcement approach really is the most important factor in getting kids immunized. Next. So these are the posters that I alluded to. The poster on the left is a poster that was hung in each of the lobbies, and it basically introduces HPV vaccine as powerful cancer prevention starting at age 9. And you can see it has a diverse representation of preteen children. So this was just getting the message started in the lobby. Then when patients entered the exam room, they saw this large poster, and this is similar to the posters that we used in the 2 clinics. And basically, we went from birth to age 18, and it was tailored to each clinic's vaccination schedule. We know clinics can decide which infant vaccine to do, and there's a lot of variations that can be done within the schedule. So the clinic could decide on one schedule that they expected everyone to do, and build their EMR around it, that this is what we posted on here. You can see in the red box that HPV vaccine, 2 doses were recommended starting at age 9 to 10. And I have to tell you, the providers uniformly said the giant poster is magic. One senior provider who'd been in practice 25 years just said to me, "I had no idea how powerful this poster could be. It's like having a second voice. It really starts the conversation with parents, and parents and kids are starting the conversation with the medical assistant and with the provider. They're making sure that nobody forgets to get the child vaccinated." Next. So we looked at our rates of at the 9 to 10-year-old well child visit, how many of those kids actually received the HPV vaccine on the same day as their visit. And what we found is that this is a very acceptable strategy to both providers and parents. On the left are the results for Clinic A, and on the right for Clinic B. So Clinic A, you can see at baseline in 2018, a few providers were already starting to give vaccinations at 9 to 10. They were kind of the early PDSA, Plan, Do, Study, Act volunteers. And then in 2018, all the providers started when we had the policy change. Now in 2022, 86% of the 9-year-olds arriving for their 9-year-old well child checkup walk out with their HPV vaccine, and 86% of the 10-year-olds who arrive for their well child visit walk out with the vaccine. So that's amazing, the majority of patients. Now, Clinic B, remember, has only been doing this for 1 year. At baseline, very few patients were recommended to get the vaccine at age 9 to 10. And then now in 2022, 68 to 70% of the patients seen for their 9 to 10-year-old well child check receive the vaccine at that visit. That's remarkable, and it shows how swiftly this change can happen in a practice. Next. So how did it affect our rates? And we wanted to develop a metric that we could use simply. We didn't want a lot of data collection, and we wanted to be able to compare clinic to clinic. So we used our Washington State Immunization Information System, WAIIS, that's a mouthful. And we looked at the coverage rate reports and kind of an interval basis, pretty much about every 3 months. Maybe for Clinic A, we did it more frequently initially. But what we found was that the coverage rates at age 9 to 10 for first dose HPV really rose dramatically in both settings. And in the very first 12 months, so the first year, it rose by 30% or more in both clinics. And then Clinic A, the first clinic, they reached kind of a plateau around 50 to 51%. And you might wonder, well, will this ever get to 100%? And the answer is no. And part of that is because coverage rate reports include kids who turned age 9 today, and they haven't even had a chance to have a visit. And some kids won't have a visit between ages 9 and 10. And coverage rate reports through the IAS do include patients who are no longer active. So you can never get to 100%. That's just for the IAS people. Okay, next. So then we look to see how is this impacting our coverage rates for HPV initiation and completion at age 11 to 12. And again, on the left is Clinic A and on the right is Clinic B. The top graphs are for the initiation, the bottom graphs are for completion. And you can see the graphs slope upwards in all 4 graphs. Remarkably for Clinic A, they increased their completion rate by a full 40%, up to 62% complete at age 11 to 12, and up to 89% of those kids had initiated. That's remarkable. Clinic B is just starting their journey for 11 to 12, and as kids age up, the 9 and 10-year-olds that were vaccinated this last year are aging up. That will start impacting the rates at age 11 to 12, plus the poster and the other, policy and the EMR prompt, that's actually kind of moving the whole tide forward anyway. Next. So you might wonder, how did it start? Why did Clinic A decide to do this? And this started with the Dear Provider letter, which I call the permission slip. So if you're a state leader, this is the time when you need to pay attention because you have power to support providers to make this change. So this came out in 2017 and from the state epidemiologist. And it basically encouraged providers to start at age 9. What this told clinics and providers is it's okay, and actually it's a good thing, and it doesn't contradict CDC. So this was really important to get the work started. Next. And I'm going to now weave in other things that for state teams, and so I'll give you the sort of your action items now, and then I'll explain them. So if you're a state team, a leader, I want you to do these next things. This is why I want you to lean in, so everyone lean in, and these are the action steps. First, I want you to familiarize yourself and your team with the Start at Age 9 resources. I'll show those in a minute. I want you to learn or figure out, how do you educate the providers in your state? Maybe you host a webinar. There's a lot of great videos out there that can quickly tell the benefits of starting at age 9. Maybe in your quality improvement projects, you really want to have starting HPV vaccine at age 9 as one of your interventions. And the Dear Provider, send one of those. Make it an official stamp of approval that your state recommends starting at age 9. Then think about your forecasting. What does your IAS forecast look like? Does it even include HPV at age 9? And how about your metrics and your dashboards that providers and the public can see? Are you starting to measure the rates at age 9, 10, or could you? I think data is important. If you start looking at the data, you can follow your progress. So I'd like you to go back to your state's leaders and find out, what does your forecast look like? What does your dashboard look like? Could we make a change? All right, next. So this is just really quickly, these are some fantastic resources from the HPV Roundtable. They've developed an evidence summary. This is in the middle is their standardized poster. It's amazing, and it focuses on the preteen teen vaccines. There's toolkits, video links, social media posts. So this is your one-stop shop for age 9 resources. Next.
1 minute, Sherri.
And then, great. The last thing is thinking about your immunization system. So HPV can be forecasted, and I call this sort of a spectrum. If you look at a patient who's age 9, will the HPV even be mentioned? In some states, it's not even mentioned till 11. Some states it is mentioned, but says it's not due, or it's optional, or it's due now. I'd like to see all states moving their forecast all the way to the right to due now at age 9. Next. And I think this is kind of my last slide. So this is an example of where we are in Washington and where we're trying to move to. So this is a forecast for a 9-year-old. It says that the recommended date is age 11, the minimum valid date is age 9, and it's optional to get now. So we're in the red box, we're in the optional, you can get it done at age 9, but we're trying to move to do now. And I would like to see other states moving that direction too. You can do it, it just requires some, working with your IAS team, and they have to work with the platform or the vendor to get these changes made. But these are really important, and this is how you can encourage providers to do this work. Next. We're not going to go over this, but this is a great video for you to watch that kind of summarizes my whole talk in less than 2 minutes. You can watch it later. And I think that's all I have. So just as just a final sort of statement, if you're a state leader, take these messages, lean in, and start supporting the providers to do this work, because age 9 is where it's at.
Where it's at. Thank you, Dr. Zorn. I learn something new every time I hear you speak. And there's a lot of questions for you in the chat box, but everybody, I want to ask you, in the bottom, I believe right corner of your screen, you have 3 dots, and that gives you the option of opening the Q&A pod. So it would be helpful to us for the next 2 speakers. The chat, we're broadcasting info to you, so you have take-home information and links. We want to use the Q&A so that speakers can reply to you. So going forward, if you can use the Q&A box, that would be ideal. So we've got another Mentimeter question up right now. What is one benefit of starting HPV vaccination at age 9? Getting completed, more protection, better immunity. Yes. Higher parental acceptance, more time. I know I wrote down 4 years to get those 2 doses completed by age 13. I was listening, Dr. Zorn. Fantastic. Wonderful. Thank you so much for that participation. And as we said, there's a lot of great takeaways. So let's move to our second speaker, Ms. Samantha Olds Frey. Ms. Frey is the Chief Executive Officer of the Illinois Association of Medicaid Health Plans. IAMHP advocates for public and private health plans, including improving access to quality health care for the uninsured, enhancing consumer choice, and improving affordability of health insurance for all Illinois residents. She has over a decade of experience in healthcare and appropriations policy, and as CEO is charged with coordinating legislative strategies and working closely with state agency administrators to formulate and implement policy that positively impacts Medicaid members. We're big fans of your work. In 2015, she was even named to Forbes magazine 30 Under 30 for her work in public policy. Samantha, welcome.
Thank you so much, Jennifer, and thank you all for joining today to talk about this very important topic. I'm going to focus on the role of collaboration and what it means to partner across industries and partners to really sort of move the needle and improve vaccination rates and pool resources. As we go to our next slide, I think it's important to just sort of understand who IAMHP is, because that is really going to color my presentation today. And so we are a member-based organization. We represent the full industry of Medicaid managed care organizations that work in the state of Illinois. And we only focus on Medicaid health plans. So while we'll go through in our next slide the various plans that we have here at IAMHP, you'll see common names like Aetna, Blue Cross Blue Shield, and Humana. However, our focus is exclusively on the Medicaid population. And so the conversations we have with our state partners are really only focused on Medicaid. And that's critical as we talk about HPV vaccinations, of course, because in our state, as is common across the country, we cover about 1/3 of the children in Illinois. And so the Medicaid program has a real opportunity from a public policy perspective to drive change, both at the health plan level, but also at the provider level, given that there are plenty of provider groups who don't necessarily participate in Medicaid for their adult population, but they do for Medicaid because Medicaid covers such a large portion of the children. And we will dive right into our next slide. general background is I'm going to talk, of course, from Illinois, and there are just some basics that I'm going to go through real quick so you sort of understand our landscape. Over 80% of Medicaid members are enrolled in an MCO, and so that's critical. The Medicaid managed care plans are responsible for their health care. We've had in Illinois historic challenges with vaccine administration. Due to policy changes in the past gubernatorial administration, there were some VFC changes, and they came along with some technology changes that we had here in Illinois. And so that really negatively impacted our vaccination rate here in Illinois. And it's just a reminder, especially to state leaders, that policy changes have real world effects. And so we saw almost immediately our vaccination rates decrease, and we really even saw practices stopping vaccinating certain children enrolled in CHIP, which was quite concerning. And then, of course, those historic challenges were exacerbated by the COVID pandemic and a drop in well-child visits and vaccinations. And so we're really digging ourselves out of a hole here in Illinois. Let's go ahead and go to sort of key policies. And I think these are critical for moving towards success and things that we sometimes take for granted in Illinois, but are not necessarily the case in other states. First and foremost, HPV vaccination has always been a part of the quality program for Medicaid MCOs. And so we have been measuring this, we've been reimbursed and received quality payments from the state around HPV vaccination, and our data is consistent, and we've done this year over year since we've really rolled out our Medicaid managed care program back in the bulk of it in 2014, 2015. So a long time here where we've just always been measuring HPV vaccination and prioritizing it. Transportation is a covered benefit. One of the social determinants of health that we hear often from Medicaid members and from practices is that transportation is the issue. And so transportation is a covered benefit, and it includes alternate sites of care. And that's critical because what we see time and time again, both for COVID vaccines, but really all vaccines, including HPV, is that the Medicaid population is far more likely to utilize public health fairs, public local health departments, pharmacies, and alternative sites of care for vaccination. And we want to make sure that we are removing any barriers to utilizing those alternative sites of care. And then finally, Medicaid MCOs receive vaccination data from IDPH's vaccine database. So we receive this information, we received it normally monthly. Once we started to push for COVID vaccinations, the COVID vaccine drive, we actually started to receive the information sent weekly. And this is critical from a policy perspective because it gives us a fuller picture. Again, our Medicaid members are far more likely to go to a health fair, as I've already mentioned, and oftentimes at those health fairs, there's not a claim associated with the that vaccination, which means the health plan is sort of flying blind and unable to accurately prioritize Medicaid members and outreach to those practices. It is critical that we get this information so that that the plan effectively uses their resources, but then also that we can communicate with the providers on where there are care gaps and how to close those care gaps. That's something that really the MCO can serve as an aggregator, that the provider may not have all that information. Our vaccine data here in Illinois, it's not queryable, like you can only look up individual member by member. And so what we see often is that providers aren't looking at their panel's information in iCare because they would have to look up each individual member. They're relying exclusively on their health records or their EHR. And so the Medicaid MCO has an ability to really serve as that aggregator and assist that provider in focusing conversations and outreach where it's most needed. So we'll go to our next slide and talk about what IAMHP did and how we sort of convened and used collaboration to take action. So again, we represent the entire industry. We had several internal presentations from vaccine partners, really highlighting what you all know and feel and see on a regular basis, which we have not dug out of the drops in well-child visits and vaccinations associated with 2020 and the height of the COVID pandemic. Further, the Medicaid population is more impacted than other populations. So while there has been other rebounds for like commercial covered populations, the rebound for the Medicaid population is the lowest. And then the rebound for the adolescent population, sort of this age range where we want HPV vaccinations for that 9 to 13, is the lowest of all of our populations. And so we knew that there was a lot that we needed to do. So I had convened the chief medical officers and population health managers at every Medicaid health plan, along with policy experts to discuss vaccination rates and potential solutions. So the entire industry and clinical leads talking together about what we can do. And so what we did and what we decided to do was accelerate vaccine education campaigns. So normally those happen in August for back to school. We moved them up to June. Again, the reason was to start that outreach, get folks back in the clinics, get folks back in the office to get those vaccines, and recognizing that there was going to be a lot of catch up and that provider capacity was decreased. So we needed a longer runway. So we did that collectively. We also created and had provider education opportunities. So we had several webinar series on vaccine hesitancy, vaccine program management, care gap reports, and available resources. Again, as you guys sort of indicated early on in this presentation in the survey of like what you were looking for, resources on vaccine hesitancy or how do you get care gap reports, we put that all together for our provider partners, hosted a series of complimentary webinars, recorded them, put them out on our website, and continue to refer back to them in areas where there hasn't been a change. We've also created a vaccine toolkit with information on vaccine hesitancy, tools to create a vaccine campaign, including just sample texts and letters, links to recorded webinars, transportation benefit, and additional resources. Again, somewhere to really have all of these resources live and be updated as appropriate for all of the health plans. I think that's something also that streamlined it for the provider community. This wasn't Aetna creating a resource and then Blue Cross creating a resource and then our local county care creating a resource. It was one collective resource that had information on how to pull, transportation benefits for all of the plans rather than one-offs. And then we sent that out to our distribution and through the association, but also the individual plans sent out those resources to their providers as well. We'll go to our next slide. And I touched on this already, but I think it's critical that we underscore the importance of data. So first and foremost, the MCOs create care gap reports for all Medicaid members and share that information with their provider partners, typically through provider portals. However, there are other ways that our providers here in Illinois can receive them as well. And again, why those care gaps are critical is we have a broader view of the data, of the information. And so the MCOs serve as that, can aggregate that data from several sources, including claims from other providers and IDPH data, and allow providers to focus their resources and their conversations on the patients who need those conversations. Again, you don't want to necessarily talk to a patient who's received their HPV vaccination at age 9 or 10 at age 13 about initiating that, right? We give you a fuller picture of what's going on. And we are talking about how do we use that data now to sort of continue to move that ball forward? How do we at the health plan start to communicate with our provider partners about starting at age 9? Do we have those prompts within our information out to our providers in those care gap reports? And so we're starting to use that information to further the conversation beyond where we already are. So we go to our next slide. You can see this is our immunization toolkit, talking about recharging routine immunizations. You can see the full toolkit. In terms of success, we've received positive communication from the provider community on the toolkit and have actually been asked to pull together toolkits for other subject matters, including transportation and prenatal and maternal health care, based off of our vaccine and immunization toolkit. So we really have seen it as a success and something that the provider community in particular really appreciated. And I believe part of the reason for that is that it took resources that already existed and put them in one place. So the provider's office didn't have to go through the various provider and member manuals for every health plan. They didn't have to, pull these different resources together individually. And then we also made it easy with sample texts and emails and letters so they could just honestly copy and paste, as opposed to spending the time to draft their own letter on outreach regarding vaccines. We also have our webinars that we did, and we will send them out sometimes when a provider asks for information. We will refer to them to those recorded webinars. One of the most popular ones was with one of our health plans on how to pull those care gap reports. We're actually scheduling another webinar on that because, again, it's a resource that exists, but it's only beneficial if the provider community is aware that it's out there and it feels comfortable in using it. And so we're continuing to do that education so that those providers have the information they need to implement productive and effective vaccination campaigns. And we'll go to our next slide. And so from a policy takeaway, what I would really say is that collaboration expands your impact. And I sort of glossed over this accidentally, but not only did the health plans accelerate their vaccine outreach, we also work with the Chicago Public Schools to accelerate their vaccine outreach simultaneously. For those of you who don't know, in Illinois, Chicago Public Schools is our largest school district in Illinois, and about 50% of our Medicaid members reside in Cook County, which is where Chicago is. So again, working with CPS, really amplifying that message of getting your vaccines in a timely fashion. Quality programs are critical in establishing the state's priorities. You are, as a state, when you have the various quality programs and HEDIS measures, you are telling your health plan, this is what we want you to focus on. And silence speaks volumes. And so if HPV or the combo vaccine measures aren't in there, you are not telling your health plans to focus on vaccinations. Transportation is a common social determinant of health, and that it will need to be addressed. For health plans, if you are in a state where alternative sites of care are not a covered benefit, I know that some of our plans here in Illinois have actually expanded transportation benefit beyond what the state covers to include a secondary trip. So for example, a trip to the doctor's office and then a trip to the pharmacy. Expanding either at the state level or at the plan level is something I would highly recommend if you're going to really move the needle on these items. Public health data is vital to programmatic success for the Medicaid population. Our members really go and receive vaccinations in non-traditional settings more than the commercial population does. And so having that public health data is going to be critical for focusing the outreach efforts effectively and have the full picture. We at the MCO space and the payors have a role to play with regards to data sharing and outreach. Really want to be your partner in this. It is a shared goal, and it has such a broader public policy and public health implication that we want to be a part of. And then, of course, the state's Medicaid reimbursement and ease of understanding it will absolutely impact vaccination rates. So that was some of our challenge that we had in a previous state administration, were changes around reimbursement, and we saw a negative impact to that. And so it does have real world impacts. To learn more about IAMHP and to get information on some of the webinars that we do have coming up, do feel free to engage and subscribe to our quarterly newsletter. But here you'll also find the podcasts and webinars and articles we've written around vaccination. And that's all I've got.
Thank you, Samantha. That was so much wonderful information that we have to cover in the panel. But again, it reminds us the power of when you go from one to many and you engage all of those collaborators and you find solutions for all based on data. That's how we're going to have the big wins in the recovery. And because you covered so much on policy, I want to briefly turn before our third speaker to Dr. Heather Brandt, because I know that St. Jude's recently released a report that is in the chat box. So Heather, let's have you speak to that.
Yeah, thanks so much, Jen, and thank you, Sam, for that amazing presentation focused on policy. So we recently released a report, Analysis of Public Policy Decisions and Factors Driving HPV Vaccination Coverage in the United States. And it probably won't be a surprise to you when you take a look at those 5 public policy recommendations that several of them were touched on in the recent presentation here. The 5 include leveraging meningococcal conjugate vaccination as a model for improving HPV vaccination. The second is a focus that we heard from Dr. Zorn on training healthcare providers and practice staff and making system level change. The third one is focused on improving access points, especially as part of the federal Vaccines for Children program. The fourth one is absolutely focused on data and systems. We need better data to understand vaccination coverage and where our efforts are most urgently needed. And then lastly, for states, including the 12 in the United States that have not yet done so, we know expanding Medicaid makes a difference when it comes to HPV vaccination. And the link to be able to access this full report and all of the currently available information, state level estimates are coming soon. I'll put the link in the chat. Thank you.
Thanks, Heather. And I know Duha already launched our next Mentimeter. So after listening to Ms. Frey's presentation, do you see opportunities in your state to collaborate with state Medicaid organizations? The votes are coming in. We have a lot of people. The majority are saying yes, and then a good number here who are thinking maybe. So Samantha, I think we've planted some great ideas here. So I'm very excited for the panel part. So next, we're going to turn to our third presenter. Ms. Katie Crawford has been with the American Cancer Society for 14 years. She started in Indiana as a state health systems manager. And in 2017, with her partners at Indiana's Immunization Coalition and the Indiana Department of Health, she helped form the Indiana HPV Stakeholder Group. She's the immediate past chair of the Indiana Cancer Coalition since 2017. In June 2021, she took a national role focused on expanding ACS's work with health plans and supporting HPV state engagement. So Katie, welcome. Katie, you're not unmuted yet. We don't hear you yet. I think we're having some technical difficulties. Katie let us know earlier today, because this is the way of the world, that her power went out, and so that she was trying to call in as well. So Katie, you're showing as muted. Maybe can you try to dial in? In the meanwhile, let's remind everybody, I see some more questions that have come into the Q&A box. So please continue to post those there. Our last 15 minutes will be with the panel, and we want to make sure that we can address those.
Jen, this is Heather. Maybe we could do an audible here and maybe take some questions for Dr. Zorn and Samantha while we try to get in touch with Katie. Would that be okay?
Let's do that.
Okay.
Thank you.
Yes, thank you. So Dr. Zorn and Samantha, if you guys would turn on your cameras. Thanks.
So I captured some questions for both of you. Dr. Zorn, there was a desire to clarify. Are you saying that at ages 9 to 10, we should recommend or deliver the HPV vaccine? Is it both, one or the other?
I think you should recommend and deliver. But if a patient says no, then you give the recommendation, you give them information they might need, you find out what their concerns are, you answer their questions, and then you kind of plant the seed that you'll get the vaccination at age 10 then. So I usually say if a patient at 9 declines, like, no problem, we can do it next year at your checkup and make a plan for that. So, and in our data, it was the 86%, that was people who walked out with the vaccine in their arm. I'm expecting that 100% got a recommendation and 86% said yes.
That's very high, 86%. That's incredible. Someone else wanted to know, did you offer maintenance of certification credits for any of that provider ed or QI
for
work?
Clinic A, no, because it was sort of happening grassroots. It wasn't, but for Clinic B, they did get maintenance of certification hours. And that was important because they had a large group. They needed to be efficient, right? Do the work, get some credit, make a difference, and make it win-win for everybody.
Okay. It looks like we have Katie back. Katie, do we have audio? I see your lips moving, but not talking. Okay, so apologies for this as we work on that. One more question. Did you see any difference, Dr. Zorn, in the uptake between males and females at age 9?
You know, we really didn't. Maybe they were different, but 1 to 2% in either direction for both Clinic A and Clinic B. Once we found that they were really similar, we didn't go to ongoing tracking of them because we really felt like that was just took too much time and we hadn't noticed any big difference. So we just lump all kids together, doesn't matter their gender.
Okay. Samantha, one of the things that caught my attention is you mentioned about convening the CMOs and population health leads from all of the Medicaid plans. How did you do that? Is it just because they're members of the association, or what were you able to leverage to get their attention on immunization?
Oh, great question, Jennifer. So we actually regularly meet with our chief medical officers and quality and population health leads at all of the health plans, actually meeting with them tomorrow for this month. So we have, as an association, regular meetings with those clinicians and to talk about QI strategies, best practices, and outcomes and challenges. So for us, it really wasn't a deviation from our standard practice. We meet with them regularly, and how we initiated the discussion specifically on HPV is we actually worked with a partner who had some data. They came to us and asked if they could present to our CMOs. They did so, and our CMOs were incredibly alarmed and started taking action, within the next few weeks.
One more question, and then I'll try Katie again. On your slide, you noted about alternative sites, and I believe there was something about Chicago Public Schools being engaged. Is there anything you want to share about using schools as alternative sites?
So we found that school fairs, back to school fairs, either at the school or maybe the park nearby, and partnering with community-based organizations is incredibly powerful. And so we cover transportation to those fairs for the purpose of vaccinations and have found a real benefit there. We also couple that with back to school supplies, food boxes, really trying to draw our Medicaid members in and then have them also receive critical vaccinations.
Fabulous. Thank you for that. All right, Katie, try number 3. Are we lucky?
Can you hear me?
Yes, we can.
Boy, that's one way to get your heart pumping. I'm so sorry. My neighbor's having intermittent outages, and they literally just killed the power as soon as they were going to introduce me. My apologies. Okay, so I'm going to jump right in. I'm Katie Crawford. I'm with the ACS, and today we're going to talk about how we collaborate with our partners. And again, I'm sorry, I have no light. I'm on my hotspot, so hopefully you guys can see me okay. So as we move through this, I want you to think about your role and how you engage partners, and if there are ways that you can engage partners in collective learning endeavors. Next slide. All right, so first we're going to talk about collaboration with health plans. Next slide. Right now, we are working with our health plans on a learning collaborative. So what is that? A learning collaborative is designed to help health partners close gaps in care and reduce costs by creating a structure in which interested organizations, there's buy-in with these organizations, can easily learn from each other, from recognized experts in the topic areas that they want to make those improvements. Next. All right, so what are the benefits? Why do our partners engage in this learning endeavor with us? It gives them time to prioritize their performance measure. They have access to experts. It allows them to benchmark their progress in comparison to others. They're able to gather those promising practices by learning and hearing from their peers in the area. And then they also have the ear of their peers to do active troubleshooting. And also, we know this work is hard. So working alongside others gives us a chance to celebrate those wins. And that's really wonderful as well. So why do we do it? Well, we can expand our reach with impact with fewer resources. We can engage multiple partners at once. We have a continuity of support. We're working on a set timeline. And it allows us to create those connections between partners. I've seen that, in the learning collaborative that we're working on right now. We were able to present an idea. It was of interest to a partner. We connected them. The other partner is going to implement the same type of project in this coming year. And then we also are able to collect that outcome data to help better tell our story here at the American Cancer Society. And it obviously reduces travel expenses for our staff as well. Next slide. So what are the core components of learning collaboratives? You're going to focus on a specific quality measure. You're going to focus on that quality improvement process. We have a consistent timeline in place. Ours here at the American Cancer Society are typically 1 to 2 years. It's data driven. You've got to look at that data to understand where your opportunities, where your challenges, and your room for improvement are. And then the collaborative sharing process. And this is such a key element. And at times it's difficult to draw your partners out and get them comfortable in sharing their challenges or their difficulties, but is such an important part of the project. Next slide. Okay, so this is what we're looking at here at the American Cancer Society. In 2021, we held a very small pilot project with health plans focused on HPV vaccination. We rapidly expanded that this year. We touch over 20 states with almost 30 health plans participating. And they represent 41 different product lines between exchange, ship, and commercial and Medicaid. Next slide. These partners serve or have the ability to serve over 17 million members nationwide. They reached, can you hit? Yes, thank you. They reach over 205 active 13-year-olds in this cohort. Next slide. Right. Some of the various topics that we've covered are using data, so really understanding where those missed opportunities are and how they can better support their providers and members with those opportunities. Starting at age 9, and while that was a single topic, it has really become sort of the overarching theme of the project. We talk about the benefits of starting at age 9 in every session. Provider and member focused interventions, combating misinformation. Obviously, in the time of COVID, this has been a huge struggle for us. So really understanding lessons learned and that what the responsibility of our health plans and partners are in providing timely and accurate information to their members. And provider recognition and feedback, we're about to embark on that topic soon, and then implementing quality improvement at a practice level. Next. So here's the timeline. So this is for next year, but it will be the same year after year. We start recruiting in the fall. By December, our committed plans will receive their baseline survey link. That is due, we'll start the project 1st of January. Their baseline survey is due 1st of or early February. We do implement at the touch point data. And then the project concludes at the end of the year with their final data due end of January next year. During that time, we will have bi-monthly topical calls with the health plan, as well as offering technical assistance to the ACS staff monthly that are working with those health plans. Next slide. Right, so what are some of the lessons that we've learned? One, the participation provides our partners accountability. They want to work on this measure, but sometimes other things come up. So by joining this endeavor, it allows them to say, nope, we have made a commitment. We are going to continue to prioritize HPV vaccination and the IAMHP measure. The peer showcases are so important. They really enjoy and gain a lot of information and hearing from their peers. And then really focusing on data, really encouraging those health plans to disaggregate the IMA measure and to look at each one of those vaccinations as a standalone vaccine and how it's overall impacting their measure is really critical. And then being able to have access to the experts. So when they want to make policy changes and shifts, like starting HPV vaccination at age 9, they're able to hear from experts like Dr. Zorn and like Samantha that help them build the case with their executive. And the materials. They love materials that are turnkey, that they can just push out, and they know they're trusted material. Next slide. Okay, so now we're going to talk a little bit about our collaboration with health systems. I don't lead this work. My wonderful colleague, Amelia Sloan, does. So if you have questions, send them our way, and we'll make sure Amelia is able to answer those. So we are fortunate at ACS that our HPV projects fall under the HPV department, essentially. So this is our vaccinating adolescents against cancers. And this is our work working with health systems to implement quality improvement activities to improve HPV vaccination rate. Next slide. And we have been very fortunate that we've been able to prioritize this work since 2015. So over the last several years, we have implemented over 300 projects with health systems. A total of 212 health systems have participated, reaching over 2,000 clinics. So this is something that our staff nationwide is really adept at doing. But as you can see from the map, I want you to think about where you're located and are you working with ACS? Are you working with your health systems or health plans? There's more opportunity there for us to engage our health partners. Next slide. All right, so all of these projects have an overarching goal of increase on-time HPV vaccination. As I mentioned before, we're using data to inform all aspects. Where can we make positive change? Implement effective evidence-based interventions. Securing leadership support is critical. When we have a leader champion on these quality improvement teams, the project improvement is just, it's more impactful overall. Creating that comprehensive quality improvement plan with the ACS staff partner, making sure that we're at the table, we are supporting your efforts, and that we're bringing the resources that ACS has, as well as the partners that we work with as well. So, and then creating that culture of team-based quality improvement. Everyone has a role and a responsibility, making sure that everyone from, the individual that schedules the appointment, that checks the patient in, that gives the recommendation and actually gives the vaccination and schedules the follow-up appointment, everyone has a role and they're all on board with buy-in. And then executing a sustainable and meaningful process improvement. Next slide. So this is the framework we recommend for the Institute for Healthcare Improvement Model. So form a well-rounded team. You're going to assess your baseline data. Set that data-driven aim statement. We will increase HPV initiation by X number by X date. Create that action plan. And then explore the processes and gaps to customize and test your EBI. So running through that PDSA cycle. And then track your progress and celebrate your success. We want to encourage everyone to recognize that, every time they see a 1 or 2 or 3 point improvement, that those are kiddos. So that's something to celebrate. So all of these projects with our health systems are local or regional, led by our ACS staff, and we have some super talented staff. So this is what we recommend. They are typically hosting a quality improvement boot camp. So this is going to be a 1 or 2 day event with their health system, and they're going to go over all the tips, tools, trades of quality improvement work. They will facilitate regular virtual learning meetings with their health systems. Some meet monthly, some less frequently. We recommend at least 3 to 4 times a year. So provide virtual or in-person assistance. And then where possible, obviously the pandemic has shifted how we work, but provide some in-person group can. All right, next slide. So we see that more touch points equals higher rate change. We have some projects that they're just submitting data at the first of the year and at the end of the year, working with their ACS staff person. But when you add in additional components like a learning club or additional progress updates, we see more impactful projects. So as you can tell in this first one, folks that were participating in a learning collaborative for initiation, they saw an 8.1% increase as opposed to those that weren't participating who only saw a little bit over 1 percentage point increase. So, and again, with progress updates, just making sure that we're well aware of our data and that there's more accountability to it. Next slide. Okay, so we've talked about health plans, we've talked about health systems. Now we're going to dial in, and I'm here in Indiana on a case study from collaboration with one of our coalitions. And I'm going to talk about a project that started in 2018. And this idea originated from a HPV workshop that I believe was hosted by the CDC, ACS, and the HPV Roundtable. We brought our State Department of Health as well as our coalition and our American Cancer Society representative to the table. We heard from other great states that were implementing really impressive strategies, and we really just sort of picked some of those up and ran with it. So we are fortunate, or we're fortunate here to have an HPV stakeholders group. So we took the idea of this provider letter back to the group, where we had all of the managed care organizations participating. They loved the idea. We worked with the American Cancer Society and the coalition, led in authoring the letter, updating the letter, and then soliciting our partner support. And so we put this out in 2019. The Indiana Department of Health, our Medicaid department, actually sent this out to all of the providers in the state. And then next slide, and my power just came back quickly. It doesn't glitch. Okay, am I still with you guys?
You are.
Okay, so sorry. Oh, okay, so fast forward to 2021, we were fortunate to get back in person for a roundtable meeting here in the state. Our managed care attended. They indicated a need in updating the letter and expanding the letter to have a parent component as well. So the wonderful stakeholders here were able to do just that. They updated the letter and then added a parent component as well. They were able to solicit even more support from stakeholders. So as you can see, there's about twice as many logos represented on this. And next slide. All right, but this work takes time. So this is the timeline. As you can tell, it's taken a little over a year at this point to get the letter drafted, get it approved, get it, out to everyone, logos on it. So my parting thought is don't just get discouraged. This work just takes time, but it's very impactful. Next slide. All right, so some of the next steps for distribution are the MCs work together in doing network notifications, providing the letter in their newsletters. They'll be sending it out to them. It'll be available in a Provider Friday forum. They're also coupling it with an HPV toolkit on the website. And then they will be divvying up the members to send them the letter to their members as well, via snail mail, as well as email, and lots of different ways that they're going to make it available. And then they're going to work with all of those logos that you saw and do a coordinated social media campaign. Next slide. Okay, so closing thoughts. Whew. So I think the overarching sort of goal for us is getting back on track. When we have this shared goal of getting back on track with adolescent vaccinations, and we're able to work with our partners, we see impactful work. We all are working towards the shared common goal. Next slide. All right, so a couple things. So I think there might be a poll coming up. So how are you using your state IIS or VFC ordering data to inform your partnerships? So think about last month's presentation and the various data sources that we talked about. Are you sharing that data with your partners? Second, how are you engaging vaccinators and partners in your state to drive that progress? It's not enough just to host a, yearly stakeholder roundtable group. You really need to think about how we can be very intentional about our engagement with our health partners. And then last, where can you create peer-to-peer sharing and learning? This structured learning really spurs progress with our partners. And I think I have one more. All right, so what if, just what if, think back to that map and how there were still lots of spots and states that needed more engagement. What if your state immunization, your cancer, or your HPV coalition organized an adolescent immunization learning collaborative for 2023 and met 3 to 4 times to drive progress? What would that look like? Last slide. Thank you all so much. I'm so sorry for my technical.
Thank you, Katie, and thank you for persevering, because I know that's very stressful when the technology doesn't cooperate. Katie, if you in the chat could answer, somebody wanted to know if they wanted to engage in the ACS HPVQI initiative, how to do so. Right now, we have another Mentimeter for you, and we'd love to know. I think we're wanting to know exactly what do you think you can do with the information you just heard from Katie? What are the actions that you can take to, as she said, spur intentional engagement within your state? And you can choose all that apply. So there's using IIS data, and someone asked about that. And some states have public access to their state immunization information registry or system. Some have parent-facing versions. As Dr. Zorn put in the notes, that providers and clinicians may have other access to that information, and you can get that maybe at a county or practice level for gap reports. We can engage vaccinators. We've heard a lot about partnership today. And so Samantha, I know we have 4 minutes left, so we have 3 minutes for questions and 1 minute for the evaluation pitch. Samantha, there's a question around, in states where we might not have a Medicaid association, such as yours in Illinois, how could groups engage with state Medicaid around adolescent immunization?
So I would say there are a couple different routes depending on your state's structure. So first and foremost, there may be a commercial association that also has sort of a Medicaid subgroup. So that might be a nice place to go, of commercial health plans. You also, of course, could go, if you have a closer relationship with your Department of Public Health, reach out to your Department of Public Health and ask them to have a joint meeting with the Medicaid agency. Key legislators that care very deeply about this are another route. Alternatively, in the Medicaid space, again, every state's a little different, but I find that your FQHC association, your federally qualified health care organization, tends to have a pretty close relationship with the Medicaid agency, given the population they serve. And so outreach there potentially. And then again, other advocacy organizations like your American Cancer Society chapter or other groups that sort of are in that space are great. We have a vaccine group called EverThrive that also partners on some of this in Illinois, but I suspect there are community-based organizations that sort of champion these things, and partnering with them is really key. Finally, I would say your state Medicaid agency wants to improve vaccination rates. So if you don't have any of those or don't have strong ties, just go directly to them. Outreach to them, go to their Medicaid Advisory Committee meeting. If they have a clinician on staff, some do, some don't, or reach out there. The Medicaid directors care deeply about vaccine rates, and they've been hit pretty darn hard. So I think they're going to tend to be pretty receptive about this.
Thank you so much. Great ideas for action there. Dr. Zorn, just one quick clarification on the starting at age 9 and dosing. Is that 6 to 12 months apart starting at age 9?
Yeah, so anyone who starts between ages of 9 and 14, the second dose is routinely administered 6 to 12 months later. But a lot of doctors want to know, well, which is best? When should we really try to get our patients back in? And the data actually supports just get them back in at 12 months. And we found that was a way to streamline our clinic flow. Of course, if a patient was there sooner than 12 months and they wanted to get their vaccine done, we would get it done. We never said no at 6 months, but we weren't chasing the patients to bring them back at 6 months. We waited to kind of bring them back at the regular 12-month annual visit. So it gave us more time, and it kind of, we didn't have to do really active reminder recall, and we didn't have to put a shot-only visit. But 6 to 12 months is totally fine. We just chose 12 months as our standard.
Thank you. We are short on time. We have one final minute, and we need to put a pitch out for you to let us know how we can do even better in our third and final webinar in this series. So if you would grab this evaluation link and let us know your feedback. Please join me in a rousing round of applause for our 3 panelists today. It was absolutely our delight to learn from you. Again, you'll be getting this content back in email. I also want to give a shout out to the behind the scenes St. Jude staff, Duha and Carol, for helping facilitate making sure this all runs as smoothly as possible. And lastly, please join us in November when we're thankful for all of the process and monitoring and evaluation of impact on what we're doing. So we will have another wonderful panel of talented national thought leaders on November 15th at noon Eastern. So with that, thank you so much for making time to be with us today, and have a great rest of your week.